A story about two posters or whether New Zealand can have a real public health system. In 2020, two countries covered their walls with sentences. In one, the sentence read, "Stay home, save the National Health Service." In the other, "Be kind." Consider what each of those sentences assumes. The first assumes there is a thing. Something fragile, shared, collectively owned, that can be lost, that belongs to the person reading the poster, and that this person is capable of damaging through careless use. It is a sentence addressed to a co-owner. The second assumes people, and their moods. It asks for civility. It names no institution, claims no shared property, and requests no sacrifice on behalf of anything in particular. It is a sentence addressed to a crowd. Perhaps there was nothing to save. Perhaps, where no shared thing exists to defend, the most that can honestly be asked is that nobody kick what is already lying down. Slogans are an X-ray. They reveal what a society believes it possesses. And the question worth asking is not whether New Zealand spends enough on health. It is whether New Zealand has ever decided what it is building. Every health system rests on one prior choice, and everything else follows from it. Either medical care is a public good, distributed according to need and refused according to evidence, or it is a service, purchased according to preference and delivered according to demand. These are not two flavors of the same thing. They are two machines running on incompatible logic. And there is a great deal of evidence that New Zealand quietly chose the second, while continuing to speak the language of the first. Begin with ethics, because a profession's ethical rules are architecture wearing moral clothing. In New Zealand, a doctor who fails to tell a patient that a privately funded option exists, when the publicly funded one does not, has committed an ethical failure. In many European public systems, the failure runs in precisely the opposite direction. There, steering a patient toward private care is itself the offense, because a clinician who can move patients into a paid queue acquires an interest in the public queue remaining long. Same profession. Same oath. Opposite duties. Which tells us these are not universal moral truths at all. Each rule names what its system is afraid of. One fears leaving a patient uninformed about a market. The other fears creating an incentive to let the commons decay. And a system that must, as a matter of ethics, keep pointing at the private exit has already conceded that the public road does not reach the destination. Notice where the duty stops. It covers the private consultation. It does not extend with the same force to medicines. One may reasonably wonder why. Possibly because in a country where some treatments sitting at the very top of the evidence hierarchy are not merely unfunded but not even registered, such a duty would apply to almost every patient in the building. The working day would become a sequence of apologies and import instructions. Some obligations are politely left undrawn. Then there is the quieter evidence. Large parts of one island have gone years without accessible dermatology. Years. Nobody resigns over it. It is not a scandal. It is barely a headline. Because a gap is only a scandal in a system that promised to close it. So what is the system built on? The British answer was ethos. That answer has a cost. Ethos without staffing and without resources is not a strategy. It is a method for extracting devotion from people and calling it vocation. But the British did something else as well. They taught a population to see itself as steward of a thing it owns. Use it carefully. It is ours, and it is finite. What is the New Zealand answer? Freedom, perhaps. Autonomy. Choice. Kindness. Kindness is a virtue. It is not an allocation principle. Nobody has ever triaged with kindness. Look at how each participant actually behaves, and the answer becomes uncomfortable. Patients first. In a shop, the customer's wish is the specification. More cheese, less onion, and quickly please. In medicine, a wish is not a specification. It is a clinical fact, sometimes a useful one, and sometimes a warning. Consider a proposition rarely said aloud: wanting a medicine is not a reason to prescribe it. In certain circumstances it is a reason to stop and think, because a person who wants a drug is, in a sense, requesting the disease that would justify it. Normally, that is not how people relate to pharmacology. Notice too the asymmetry of the appointment. A demanded consultation must be immediate, convenient, and shaped like a quick repair at a garage. A review requested by the doctor, because something genuinely needs watching, is ignored. Demand is urgent. Clinical judgment is optional. That asymmetry is the signature of a market, not of a public service. Then the doctors, who are not villains but people standing inside incentives. Under sustained pressure from customers, a great deal becomes normal. 3 tablets of a hypnotic every night for years. Blends of benzodiazepines and opioids for fibromyalgia, for inflammatory arthritis, for intractable pain. A drug registered for a single dose, taken for a decade. Prescribing outside the registered indication barely registers as an event at all. Contrast a system where it is an event. In Poland, a medicine prescribed outside its registered indication, dose, or duration is not publicly funded. The patient pays, or the doctor does, through a recovery process that can reach back years. Off-label prescribing there sits close to the definition of an experiment: documentation, justification, insurance. Reasonable people can argue this is too strict, since registrations often lag behind guidelines. But notice what the strictness accomplishes. It gives every prescription an owner. Where nothing is owned, everything is affordable, until suddenly it is not. There is a practical corollary. A country that wants prescribing driven by patient preference should train its own doctors into that culture, and should think carefully before importing clinicians formed where deviation from evidence is a disciplinary matter. Such doctors do not adapt smoothly. They experience the difference as moral injury, and eventually they leave. The same absence of ownership appears in the laboratory. Access to publicly funded tests, orderable by almost anyone, is extraordinarily wide, and abundance is habit-forming. Elsewhere the funded menu is narrow by design. In much of Europe, ferritin is not measured before something in the blood count, such as unusually small red cells, gives a reason to look. Thyroid receptor antibodies are not sent for a patient with an underactive thyroid because the patient telephoned to ask and somebody clicked a box. A test ordered without a question is not diagnosis. It is noise, and noise has descendants, incidental findings, repeat tests, referrals, anxiety. But the deeper failure is cultural. It is the missing thought, the one that never arrives, that money spent on an unnecessary investigation for a patient who merely wanted it is money absent for a patient who needed it. Rationing that is never designed still happens. It simply arrives later, as cues, as gaps, as the quiet disappearance of an entire specialty from an entire region. Even the management of a clinic reveals the architecture. Where a large share of a doctor's income flows from patient copayments, an unfilled appointment is lost revenue, and the sensible manager fills it with anyone available. In a genuinely public system, the copayment exists for one reason only: to discourage trivial use. There, every additional consultation is a cost rather than income, because almost every consultation generates tests, prescriptions, and referrals downstream. The same empty slot is an asset in one model and a liability in the other. Above all this sits the absent architect. No defined basket of funded services. No coherent national infrastructure, incompatible software, no certification, no data standards, no shared record worth the name. No workforce planning, meaning no serious answer to how many doctors to train and how to keep them. And no discipline about what leaves the funded list, only about what may not enter it. A list of funded medicines cannot be a swelling bubble. Old medicines become cheap, and cheap medicines must eventually leave public funding to make room for expensive new ones. Paracetamol and most anti-inflammatories have not been publicly funded in Poland for many years. Funding there attaches to the indication rather than to the molecule. Tramadol free in cancer pain, partly funded in acute pain, not funded at all in long-term use of other kinds. One drug, 3 different public commitments, because what the public purchases is a justified treatment, not a chemical. To fund cheap painkillers and occasional sleeping tablets while announcing there is no money for modern therapy is not scarcity. It is a decision that has never been made. Which returns us to the question. New Zealand must choose either a strict, evidence-based, cost-conscious public system, or an open private market. The hybrid produces permanent friction, because it asks one clinician to be a steward of public money and a salesperson to a dissatisfied customer within the same 15 minutes. In one role, refusal is integrity. In the other, refusal is bad service. Nobody holds both roles for a whole career without something breaking. And the sequence matters as much as the choice. There is little sense in raising health funding under present conditions. Seal the pot before pouring in the water? No country should spend $1 additional on health until it is reasonably certain that the dollar will be spent in a medically justified way. This is not an argument against spending. It is an argument about order. Money poured into an unreformed system does not buy care. It buys more of whatever the system already does. There is a moral cost to getting this wrong, and it does not fall evenly. In a private system, the poor suffer. In a half-private system that still calls itself public, they suffer while being told they are covered. The people harmed most by this confusion are precisely those who cannot purchase the exit. And here lies an uncomfortable symmetry. The same population most dependent on public rationality is often the one eroding it, through demands that are unjustified and sometimes aggressive. Not out of malice, but out of instruction. People were told they are customers, and customers are meant to be satisfied. Which makes Be Kind an accurate slogan after all, though not in the way it was intended. That word, satisfaction, deserves the final piece of analysis. Public healthcare is not a satisfaction delivery service. It provides what is medically justified, and much of what is medically justified is not pleasant. There is very little satisfying about being told one has diabetes, or high blood pressure, or cancer. A sore finger, with no suspicion of fracture, should wait, and the waiting is not a defect. It is the system functioning, because somebody sicker is ahead in the queue. In a market, a dissatisfied customer is a problem to be solved. In a public system, a dissatisfied patient is sometimes evidence that the system is doing exactly what it was built to do. And any institution that measures itself by satisfaction will, in time, become an institution that manufactures satisfaction, which is far easier to produce than health. So, can New Zealand have a real public health system? Nothing structural forbids it. A small, quite wealthy country with a single national purchaser of medicines and 5 million people is, on paper, a less complex problem than most nations face. What is missing is not money, and not talent. What is missing is a decision, and the willingness to say aloud the sentence that every genuine public system is built upon, not everything you want, but essentials you need, for your health. Say that sentence, and mean it, and something then exists that can be defended, protected, and saved. Then the second poster would finally have something to be kind about.